Good afternoon, Chairman and colleagues. The topic is surgical management of optic disc pit macular detachment without laser. The definition for the optic pit is developmental malformation of the optic nerve head. This is a small depressions in the optic disc, and first described in 1882. This is a very real diseases. Estimated 1,000 people in the general population, and usually age from 20 to 40. And the pathogenesis of serious detachment speculated some leaking from chorial capillaries, or there's some cerebrospinal fluid, or from vitreous cavity. And we thinking initially fluid from the pit causes an elevation of the nerve fiber layer, leading to a schizus-like inner layer separation. And Dr. Lincoln pointed an outer layer macular hole developed beneath the inner layer. And then subsequently, an outer layer retinal detachment occurred around the macular hole. Since we have high resolution OCT, this is the picture from Dr. Yutaka Imamura, and he found several OCTs and assumed the fluid from the optic pit can go directly to the internal limiting membrane space, or ganglion cell layer, or inner nuclear layer, or outer nuclear layer, or the subretinal space. So last year, Christopher described the histopathological finding from an eye bank, he using the scanning electron microscope found an revealed hole in the diaphragmous membrane overlying the nerve at the edge of the optic pit. So this historic finding demonstrated a real connection between the hole overlying the optic pit and the subretinal space. Based this connection between pit and subretinal space, we thinking the laser treatment should be logical. And Dr. Geis used the xenon photocoagulation and treat the temporal disc margin and create a chorioretinal adhesion at the disc edge for minimize the fluid, and also in the 80s and 90s, the laser treatment became the most common technique for treating an optic pit. My laser, my first experience is not for the optic pit, but for this disc column. This is very similar, just the size, I think. And here is here's the optic disc. Then the first laser is this range, and the yellow is my second time the laser range. And I treated with a circular optic disc, but still subretinal fluid there. In the 1990s, since 1990s, the treatment from the laser moving to vitrectomy. And this is some report, the vitrectomy combined with laser. And intravitreal gas injection alone can induce pneumatic displacement. That was reported by Lincoln. 1998, Dr. Klaus Heimann reported using the autologous platelets over the optic disc pit after vitrectomy. This is my patients. I used the vitrectomy with the IRM peeling and SF6 tamponade, treated 5 cases. And these 4 cases, it's over the time attached the retina. It's over the time, it's getting better. And under the attached the retina. And the anatomic success is pretty well. 4 cases is up to 10 months attached the retina. This is the outcome of the visual improvement. We see here the 4 cases improve the visual acuity, but just 1 case is not changed. In this case, got of the whole. So this 5 case is never use laser, just vitrectomy with the IRM peeling and gas. Right retina attached after vitrectomy without laser. This is also the OCT from Dr. Yutaka. See, here is the traction. And this traction can dip in the optic pit. So I think the role of vitreous traction is played the crucial role. And this is for understanding the cord. This dot means the retina, and the cord means the traction. If we cut off the cord, then the retina back to the position. Actually, long time, I'm very satisfied with the vitrectomy with the IRM peeling and gas. Last year, Dr. I couldn't see the name, and somebody new, reported, published in the ophthalmology. He had 7 cases from the 8 consecutive patients, just to me with the not laser, without gas tamponade, and 7 cases resolved the subfluid completely. So that is my acknowledgement for this disease. Thank you.